Good morning.
Good morning.
Good morning. Good morning, Dr. Payne.
Well, one of the voices sounded like Uzo, but I know Uzo is not here. So, okay, just share my screen. Okay. All right. All righty, give it 10 seconds and we'll get going. All right, why don't we go to Dr. Sergey Bebia, sorry, Sergey. This pacemaker, this is a patient with a bedside temporary pacemaker. And the patient's pacemaker is programmed AAI at 115 beats per minute. You notice that the heart rate is actually 115 beats per minute. But you notice that some of the beats have P waves with a big spike in front of them, and some of them do not. Can you explain, give me one or two explanations for why that might be, please?
I think one explanation could be that the underlying rate is very similar to the setup pacemaker, meaning that the underlying rate is about 115. And I think we can see.
I agree. I give you 100% credit for that. Yes, it's very possible that that is the case. It would be very good luck, but yes, certainly that's very possible. Any other possible explanations? So I get 100% credit for that, but there is one other explanation. Let's say, Sergey, that you are standing at the screen for about 10 minutes and it never changes from 115. If that were the case, then you'd have to think that that's not true, what you said.
Yeah, right? Sure. Yeah, because
most people's heart rate varies at least a couple of beats per minute, right? Over a few minutes. But so I give you credit for that. That's a good answer. Any other good answers? There's one other explanation. It's important that I thought I should mention.
Maybe the settings of the monitor doesn't allow to show all of the spikes, although it is paced. It's just we don't see it on the monitor, every spike.
That's exactly right. So, and this is the point I wanted to make, and I made this point last week to Tarek, which is that our ICU and many ICUs have a modality on their monitor called Pacemaker Mode. And in Pacemaker Mode, what the device does, the monitor does, is it searches for a high frequency electrical impulse, and it will augment it in the form of what looks like a pacing spike. And this is intended to make it easier to interpret what's going on the electrocardiogram on the monitor. But in this particular case, I can tell you that this patient was sitting at 115 all the time because they were being paced at 115 all the time. And the reason that the pacing spikes were coming and going, you're right. One option would be that the patient was in sinus rhythm or in an atrial rhythm that was at 115 or very, very, very close to 115, maybe 115.5. And so the pacemaker could intermittently be pacing. But what really was happening was that the monitor was having difficulty seeing the actual pacing spike of the pacemaker. And so it sometimes could see it and augment it and sometimes could not. But it's important to remember that this can be misinterpreted as intermittent pacing. Now, how would you tell the difference between those two things, between the patient being in a sinus rhythm similar to the paced lower rate limit versus the monitor intermittently demonstrating a pacing spike or not?
I would look at the box, because
exactly right.
Will show us.
Mm-hmm. What will it show you?
Well, it will show there are two light kind of bulbs that shows us when it's sensing and when it's pacing. So if I would see that the pacing bulb will be going on and off with every beat, basically, it would mean that it's pacing consistently, continuously.
Exactly right. That's exactly right. So you would go to the pacing box, and you could tell from it what the device is actually doing. And the key here is the presence of pacing spikes does not necessarily equal the presence of pacing, and the absence of pacing spikes does not mean that you're not pacing. And the other thing that's important is you want to look for the P wave. So this is a nice demonstration of how there is capture of the atrium, because we clearly see a very nice P wave following every pacing spike. But sometimes people get fooled when they see pacing spikes. They make the equivalency of a pacing spike to capture, and they are not the same. So this is a nice tracing demonstrating a problem. I have voiced my personal bias against this mode on the monitor, because I feel it can create confusion, as this monitor strip, in my view, demonstrates. But despite this, the unit prefers to have it on, and a lot of units do. There's nothing strange about it. I just don't personally think it helps, and I think it can become confusing. I think if it worked all the time, 100% of the time, it could always sense the pacing spike and always augment it, I think it would be very helpful, but unfortunately it does not. Okay, this is a 6-year-old with palpitations, and I'm going to go to Dr. Zawani to ask him what he thinks about this tracing.
Morning, Dr. Bass. So I'm first looking at the P waves, and I see it's before each QRS, and also the axis is positive in 1, 2, and AVF. And biphasic in V1. This is a sinus rhythm.
Okay, I agree that some of it is sinus rhythm. Why don't you look at the rhythm strip? Just so you know, we've reviewed this particular tracing fairly recently in EP conference. But do you think that all the P waves in the rhythm strip, on the V1 rhythm strip at the bottom, which I'm pointing to over here, do you believe that those are all the same P wave?
Yeah, I think it's it does change some, like the not biphasic anymore. In at the end, it's only positive.
Mm-hmm. Yeah. Well, again, I agree with you. I think that the first couple of P waves look a little different, right? These are inverted P waves, and these are upright P waves. So it appears as if the patient has basically at least 2 different P waves, right? This upright one and this inverted one with a shorter PR. Now, this P wave is inverted with a short PR, and yet there is no delta wave. How do you explain the shorter PR, or what would be an explanation for a shorter PR but no delta wave? Right, because normally if we have WPW with a delta wave, the PR will be shorter. But in this case, we have a shorter PR, but we don't have a delta wave, so we don't seem to have evidence for pre-excitation, and this patient does not have WPW. So what would be one explanation for how the PR interval could be shorter and yet still not be pre-excited?
It could be an aberrant pathway.
What do you mean by that?
I mean, in an extra pathway. I forgot the term exactly.
Well, what I'm trying to get at is that the P wave could be coming from lower in the right atrium, right? So what constitutes the PR interval? It's the time it takes from the sinus node to go across the atrium, depolarize the complete atrium, go through the AV node, bundle of His, and then depolarize the ventricle. If, however, the impulse were starting low in the right atrium, such as in an ectopic atrial rhythm, it's possible that the PR would be much shorter because the physical distance between the impulse of the P wave, where it's starting from, let's say it's like near the mouth of the coronary sinus, there's an ectopic focus. That would be a so-called low atrial rhythm. It's possible that the PR would be shorter because it just simply takes less time to depolar, to go from that impulse to the ventricle, right? Because you're physically depolarizing the atrium from a spot that's much closer to the AV node and the His-Purkinje system than it would be if you were high in the right atrium, as is more usual in a patient with sinus rhythm. So if you saw this, where you have, it looks like a sinus rhythm and an ectopic atrial rhythm, and you have the history of palpitations, how would you evaluate this, Tarek? So at this time, the patient is in your office, they're not having any tachycardia, they feel fine, but they tell you that intermittently they have palpitations.
Yeah, I think one way will be to place a Zyopatch, so we can, like, because the worst thing could be that the patient could be in WPW. So at that time, we need to look for short PR interval, wide QRS, and maybe delta wave.
Well, again, there's no evidence here for WPW, right? Again, I'm perhaps I'm not being clear there. The fact that there is a short PR but no delta wave suggests that there is not WPW, right? There's no evidence for pre-excitation. Now, you could have intermittent pre-excitation, that's true, but and certainly that would be another benefit of a Zyopatch or a Holter or some kind of ambulatory EKG monitor. But the point I'm trying to raise is that if you did an ambulatory monitor, you could assess to see if the patient is having little runs of an atrial arrhythmia or any tachycardia separate from sinus. So that probably would be the first step one would take. Another option would be, another thing to do would probably be to do an echocardiogram, looking to see if there is dilation or dysfunction of the heart, because that can be associated with someone being in tachycardia for long periods of time. And oftentimes young children, like a 6-year-old, may not be aware of it all the time. So just something to keep in mind.
Thanks.
All right. This is a patient in whom we're doing an EP study, and we're ventricular pacing, and 9 milligrams of IV adenosine has been given to this patient. And the question being asked is, what happened here? And I am going to ask this question of Dr. Perna Bonsall.
Good morning, Dr. Bass.
Good morning, Perna.
So when we are ventricular pacing, we see a retrograde P wave, and in approximately 1, 2, 3, 4, 5. So in the fourth and the fifth beat is where we give the adenosine, and then that's when we don't see any deflection in the HRA catheter, which means VA block after adenosine.
So that's exactly right. So just so everybody's on the same page, these are the pacing spikes are down here in the right ventricle. So VA, and we see that the earliest A appears to be in the His bundle. High RA is later, and so too are the coronary sinus. So this is a fairly normal looking VA pattern for someone who's conducting up the AV node. It could also be an accessory pathway there, but so VA, V, A, and then V and no A, and V and no A until over here. This is probably a sinus A. The reason I say it's sinus is because the higher A is earlier than all the other A's. If you remember, if you look here, our retrograde A is going up the AV node. We're earliest in the bundle of His catheter. Here we're earliest in the high RA. So Perna, if we have a VA block with adenosine, what does that generally connote in regards to the presence or absence of an accessory pathway?
So that generally means the absence of a concealed pathway.
That's right, or a manifest pathway. We can't tell if this is concealed or manifest because
Right.
I'm only seeing the V, right?
Mhm.
Right. So generally speaking, accessory pathways, I'll remind you, are generally adenosine insensitive, and AV nodes are adenosine sensitive. So if we give 9 milligrams of adenosine and we see ventriculoatrial block, that's often a good sign that there is no evidence for an accessory pathway. And this is a test that we could do at the beginning of a procedure to prove that there is or is not an accessory pathway, or alternatively, if there was an accessory pathway that was ablated, it's a good way of proving that it is gone by demonstrating the presence of ventriculoatrial block in the setting of adenosine following ablation. I don't remember this case, but I see here that the time is 1:34 p.m. So I'm guessing this was a post-ablation administration of adenosine, suggesting that it was a successful ablation of a pathway. Okay. All right. So this is a tracing that I received via my cell phone, and this is the text that I received from the fellow. Good morning, Dr. Pass, RE blank. The blank-year-old admitted for VT was on Lido and is now on propranolol. I saw a few beats of ventricular ectopy last night. What do you think? Thank you. And this is actually the arrow that the fellow was kind enough to give me to demonstrate what was concerning to them about the possibility of this being ectopy in this patient with known ventricular tachycardia. And I'm going to ask my good friend, Dr. Grace Kong, the October 2021 Fellow of the Month in the Mount Sinai Health System, what she thinks. Do you agree with your co-fellow about a few beats of ventricular ectopy?
It looks like artifact to me just by eye, and then looking at it more closely, I do think that when I follow out the QRS and the rate that it's been going at prior to where those concerning tracings happen, I can almost see the QRS trace out at the rate that it was going.
That's exactly right. Very good. There's a reason you are the Fellow of the Month in the Mount Sinai Health System. So a good way to do that is to, the easiest way I think is to set your calipers with a number of QRSs, because if you go 1-to-1, there may be very minimal cycle length variation, and you might get confused. So this is a 1, 2, 3, 4 beats of QRSs. So then I took this same caliper and I went from there, and miraculously, the next QRS 4 beats later comes at exactly on time, showing that there, in fact, are QRSs in here. It would be highly unusual with a PVC. You would expect resetting of the QRS rate, and so you would not expect there to be the next QRS to come exactly on time. So you are correct, Grace. This is an example of artifact. So. Okay. This patient had an implantable defibrillator placed, and my question for you is, this is the chest X-ray, AP and lateral, obtained the day after the procedure, and I guess, where is the ICD lead tip? And then I guess the next question I want to ask is, why on post-op day 1 are we obtaining a chest X-ray following ICD implantation in AP and lateral projections? And I'm going to ask Dr. Barris his thoughts on this question.
Okay, just following the course of the lead, looks like we're going from innominate to IVC, and then into RA and then RV. And then in terms of the tip, I'm looking at the lateral film. It looks like it's almost going even farther from anterior to posterior, whether it's going somewhat in the RVOT.
So it's pointing anteriorly though, right? This is the tip here. You agree with-
Okay, so I would say then just in the RV then, the tip.
Right. And how do you know it's not in the coronary sinus, David?
Let's see here.
Because when you put a wire in from above, it actually will sometimes naturally go to the coronary sinus. I mean, from the
I think that would be more
looking at the-
posterior.
That's exactly right. So on the AP view, absolutely, this could be in the coronary sinus, right? That's about where it sits. But on the lateral view, the coronary sinus should be going posteriorly, not anteriorly. So the other thing is, how do you know it's not in the left ventricle?
Just based off of the course of the catheter, also just appears to go from RA and then courses and remains anterior as opposed to LV again,
Right.
more posterior.
That's right. So first of all, in the RA, it's quite lateral towards the right side of the atrium. And, this is, so why do we get an X-ray, David, the day after we implant it and do it in AP and lateral view, right? We always say, send the patient down for a standing AP and lateral film.
I think some of your questions probably belie that. It's again to confirm the position of the tip of the ICD lead.
Right. What else are we looking for? That's true. That's certainly true. And I might add that I take care of a boy who at another institution, unfortunately, inadvertently, the electrophysiologist, actually a surgeon, passed a transvenous pacing ventricular lead through a PFO into the patient's left ventricle. And it was not determined until the patient had a stroke 6 weeks later. And he, to this day, has some neurological residua of this, can't use one of his hands very well. He's in his 20s. This happened when he was less than 5. So yes, so that's an important point. Anything else we want to keep track of why we're doing that? That's the most important, I would say. But what are the what are some other reasons we would do it?
So aside from lead migration, I suppose there could be just looking for other pathology like lung pathology, post-procedural.
Like what?
Effusions.
Right. Definitely, you could have a hemothorax or a pneumothorax. In this case, looking at this film, there is no hemo or pneumothorax. Do you have any thoughts on why this patient was at very minimal risk for that based on the course of this wire?
Just in terms of the vessel that you accessed.
Exactly.
So I guess if you do subclavian, then you're at higher risk. But if you access more distal, like the axillary, you have less risk for that.
Right. If you do axillary or cephalic vein, your risk for a hemo or pneumothorax is markedly lower. And you can see in this case that the entry point is somewhere around here. Okay. And so this is, so it is possible that if you're not careful, you can enter the thorax with the introduction with the introductory needle, but you really are trying your best to go there. Not only do you avoid the hemo or pneumothorax risk, but you also potentially enhance the likelihood that the lead will have a better longevity, because we've discussed in the past, the more laterally you enter the venous system, and the farther you are away from the clavicle, the more likely it is that the lead will not suffer the injury of a subclavian crush injury. And so generally speaking, entering either the cephalic vein or the axillary vein is on average associated with greater longevity of pacing, transvenous pacing leads. So in this case, that was how the patient had the pacemaker implanted or the defibrillator implanted. Okay. This is a patient with hypoplastic left heart syndrome who had a bidirectional Glenn, an LPA-plasty, and a tricuspid valve repair. And this is the EKG that was obtained in the early morning hours. And patient was noted to have a normal blood pressure, unchanged from the entire night. The lactate was 2.3, previously was 1.9. And the urine output was 1 milliliter per kilogram per hour. And here we are, it's post-op hour 7. So and the question that I was asked was, do we want to pace this patient or not? And if so, how would we pace this patient? And again, you see that the heart rate is 105 beats per minute. And this is in fact the tracing that was sent to me. And this is a projection of what I saw on my cell phone at 3 or 4 in the morning. So I'm going to ask Dr. Grace Kong what she thinks about this and whether she would do anything about this. Seems like the patient is basically meeting most of the sort of minimal requirements of a good post-op patient. What would you do? Would you leave this rhythm at 105? Would you do anything about it? Would you monitor? What are your thoughts on this?
So I would have to look at a baseline EKG, but this looks like it's JET, junctional rhythm, or possibly VTAC. But
so is it JET or is it junctional rhythm?
Oh, that's right, because it's not that tachycardic. So junctional rhythm.
And he's not that hemodynamically embarrassed, right? I'm showing you that his lactate is only marginally elevated. He is making urine. He's got a normal blood pressure, although we know blood pressure, once you have a low blood pressure, you're already missed the game. But you're right, it could be, you're absolutely right to say that this could be JET or it could be VT. I will just tell you for the sake of discussion that the patient was in sinus rhythm earlier in the evening and the QRS morphology looked exactly the same as this one.
So we think this is a junctional rhythm. The rate, as you mentioned, is not that fast. It's around 105 in a 6-month-old. And I know that our lactate is, we're only post-op 7 and urine output's a bit low and lactate slightly bumped, but I would AI pace this patient to get us through the first post-op night.
And what would you pace and how would you pace?
I would AI pace at least 20 above the junctional rate so that there's no competing. I would probably, it's a 6-month-old, so I could feel pretty comfortable pacing high. I would probably pace around 130. Okay,
I agree with that. And the point I was just making is, there isn't a right answer to this. It would not be wrong to observe this patient in this rhythm, but I think probably what you are recommending is the best answer, which is that probably we should pace a patient like this because, a lot of times it's a little bit of an experiment, right? You don't really know when you pace if the patient's going to be better. It makes sense that the patient should be better because what it appears is that the patient may have a little chronotropic incompetence with a heart rate of only 105. Somebody who just had a major open heart surgery with a tricuspid valve repair, a LPA-plasty, and a bidirectional Glenn, that's a relatively large operation. You would generally think that someone who had that would be pretty sick, at least initially in the first post-op evening. And so although the patient is okay, and it would not necessarily be terrible to leave the patient like this, we would generally always want to maximize the hemodynamics of every patient. And so I would agree with you that we would pace the A at 120 or 130 beats per minute. And typically it's a little bit of a trial and error. You would pace and see what happens. My suspicion is the blood pressure would probably rise 5 to 10 points And then you would have to look at the blood gases and the lactates over the next 1 to 3 hours to see if lactates were moving or trending in a better direction, and see if maybe your urine output were better as you have more cardiac output with a faster heart rate. So generally speaking, even though the patient is okay, we want better than okay. We want the best we can give for the patient. And so we would generally treat this. And I agree with your decision. All right. This is a patient who is V-pacing with 9 milligrams of IV adenosine. And I'm going to go back to Dr. Bonsall, who was kind enough to answer this question before in a different patient. I'd like to ask her what she thinks is happening here.
So here we don't have a VA block. So
That's true, we do not. Is there anything else that you can?
So in the third, after the third paced beat, you see that so in the first 2 beats, you see a regular pattern of the VA conduction, whereas it is sort of different in the third and the fourth beats.
Yes, it does. I agree that the third and fourth beats look different than the first and second. I agree with that. How are they different, Berna?
So in terms of their conduction pattern, they are different. So let me just look through it very carefully. The earliest A that I see here, sorry. So like in the previous rhythm we had, in the previous strip we had seen that the earliest A was in the His catheter.
Yeah.
That's how we see in the first 2 ones. But in the third one, we see it earlier in the high RA, in the third and the fourth one, we see in the high RA catheter.
That's right. That's right. So that's a different pattern. And what does that suggest to you is could be happening here?
So when you are going through the hit, I mean, if you see first in His, I would think it's going up the AV node. But here, if you see it before in the high RA catheter, then I would think that it is going up the accessory pathway.
That's right. So this is probably a patient who has a right-sided accessory pathway. And we see that we would refer to this as a concentric pattern with the earliest retrograde A's in the His bundle, which is where we would expect it normally if there were no accessory pathway. And then when we block the AV node transiently with the administration of adenosine, we see that no longer is the His A the earliest retrograde A. In fact, it's now the high RA, which is clearly earlier than the His A, as opposed to before the adenosine effect when it is after the A. So this suggests that there is an accessory pathway and that the conduction has changed retrograde from going through the AV node through going up a pathway where now the high RA, which is located in the right atrial appendage, is a little bit earlier than everything else, suggesting the pathway is not right on top of the AV node and is somehow maybe anterior or lateral or something like that. So yes, that's very good. And with that, we're done. So a bit of a brief EP conference. Thank you all very much. I will see you in a short while at Sign Out. Hope you all have a great day and a great week.
Thank you.
Thank you very much.